So today we're so excited to have Dr. Benda with us. Dr. Benda is an expert in human factors engineering and human-centered design, which are scientific approaches that investigate how people acquire, use, and interpret information. She is currently an assistant professor of health informatics at Columbia University School of Nursing. So right around the corner for us, if you're interested, she's right here. She holds a PhD in industrial systems engineering from the University of Buffalo and completed her postdoctoral training at Weill Cornell Medicine's Division of Health Informatics, Department of Population Sciences with Dr. Jessica Anker. Dr. Benda's program of research uses human-centered design to advance the inclusivity and equity of healthcare with a special focus on consumer information technology. Dr. Benda currently has an R00 award from the NIH to design an mHealth tool to support Black and Spanish-speaking Latino women reporting and managing postpartum symptoms. She has additional projects in global maternal health, improving telemedicine for patients with limited English proficiency, and shared decision-making for early detection of postpartum depression. She has nearly 50 publications in journals such as JAMA, and the American Journal of Public Health. Her work has been funded as a PI or a co-I by the NIMHD, AHRQ, NSF, NIMH, NICHD, NLM, and PCORI. And without further ado, Nat, we're so excited to have you with us. I'm going to hand it over to you.
Great. Thanks so much, Pooja, and thank you for having me here today and giving me the opportunity to speak. So as I was putting this talk together, I was trying to think about, within this idea of human-centered design interventions for health informatics, if there was kind of a common theme that I could draw that would be of interest. And given today's day and age, I wanted to focus on a trajectory of different projects that I've been involved in that relate to artificial intelligence, specifically thinking about how we can ethically and effectively implement the tools that I think many of you all are currently involved in or will throughout the course of your studies be involved in designing. So I'll talk a little bit first just about my approach to research and my background, just so you can understand, where I'm coming at, thinking about some of these problems, as well as making sure that, some of the terminologies that I'm using, that we're all on the same page as to what those things mean. And then I'm going to go through a couple of different research applications thinking about human-centered design of artificial intelligence. So I do like to give a little bit about my career path in case it's helpful for students to understand. So all my degrees are in industrial and systems engineering. I have this logo here from the Lafayette Adult Resource Association because when I was an undergrad, I actually worked teaching English. And throughout the course of my career, I've tried to include people who not speak English proficiently and improve healthcare for that group of people. I won't be talking about that a ton today, but I think it's just important to show that when you have kind of previous experiences or groups of people or patients you've worked with, that it is something you can definitely build into your career and the different things you're trying to do. And then a lot of my pre-doc work really involved creating usable, hopefully, information and studying the usability of electronic health records, specifically from a health professional facing field. And then within my postdoc, I was able to get into more of kind of a public health slant and really think about how we can involve patients in some of the health informatics work that we do. And really, at the end of the day, this graphic is just another way, although it was mentioned in my bio, that I can plug that I did my postdoc with famous DBMI alumni Jessica Anker to give myself a little bit of street cred going into this conversation. So the two things I'm going to be talking about today were grants that were funded by the Patient-Centered Outcomes Research Institute, as well as the National Institute for Mental Health. I also just wanted to show my current funding. I've highlighted the one that I'm actually going to be talking about today, but the other things I'm currently working on are there in case you're interested in those projects, and it would be helpful for us to talk about it at another point in time, since I'm not necessarily going to get to them in this particular presentation. Going into the hopefully brief amount of theory that I'll do today, I just wanted to make sure that we're all on the same page when I talk about human-centered design. So this is an approach to interactive systems that aims to make systems usable and useful by focusing on the users, their needs and requirements, and applying the human factors and ergonomics work and usability knowledge. And this is kind of a framework that I previously published in book chapters that I use when I'm designing a research study, trying to really think about the interaction of these different components and how the organizational environment the environmental context and the sociocultural background of different people affects how they interact with different health informatics tools. And the thing that I really try to do, so a lot of people who work in human factors and human-centered design have classically really focused on usability of electronic health records and health professional facing tools. But I really try to use these approaches to focus more on patients and kind of the entire patient work system, ultimately in an effort to advance health equity, although some days I feel more successful in that than others, and it's definitely a challenge. So the important point that I wanted to make is usability is particularly important in the context of AI, because if a system isn't usable, then people aren't going to be able to use it to help patients. So this is a scoping review that I guess is a little bit old in the context of AI at this point, that was done in 2021. But essentially it was a scoping review of the implementation of AI in healthcare. And, aside from the field of medical imaging, it found that although we were able to create highly predictive and effective tools, a lot of those tools are never even implemented in a clinical environment. And then this review published in 2022 also found a paucity of research where there had been randomized clinical trials studying AI that actually impacted health outcomes, which is really the ultimate goal. But the point here is that AI isn't going anywhere. And I know a lot of you do kind of the really challenging computational work of developing predictive AI or possibly generative AI. I may talk about that at the end if we have a little bit of time. And so the human-centered design approach really thinks about, okay, so you have this tool that we know works very, very well. How do we actually get it in front of people in the right format, at the right place, and at the right time, so they can use it to better help patients? And some of you may have seen this. I thought this was an unfortunate but kind of a helpful story. Thinking about human-centered design and AI, this actually just was published in JAMA Open, I believe this month. So folks at Vanderbilt had developed a highly predictive tool for pediatric thromboembolism. And they even evaluated it in a randomized clinical trial. It was randomized to different units, and they did not detect any signal or effect. And when they dug into the data, although this had a really high AUC and was accurate, I believe, about 90% of the time, and anticipating when children experience thromboembolism, the recommendations were only taken 25% of the time. So people only listened to or acted on what this AI was telling them about a quarter of the time, which the authors attributed to their potential non-significant findings. So it does, although this is an unfortunate thing to find, hopefully it highlights why some of these human-centered design and socio-technical approaches are important for an AI context. The other piece that I think is really important to think about here is inclusivity. And this is kind of the health equity aspect of the work, where we want to use inclusive design to create solutions that are accessible for, usable by as many people as reasonably possible. And for those of you that are in the first year intro to health and biomedical informatics course, what that means is we want to make sure that our designs can be used by, the large majority of people. And then maybe there are people for whom that a certain design may not be appropriate or safe, but there can also be special designs for different populations. So it's not the best New York example, but I always like to use the example of a vehicle. You're not seeing me in person, but I'm like barely 5'2". Someone else who's 6 feet tall could get in a car and drive the same car. However, people, for example, that don't have use of their legs, they may need to have a modification made to that particular, made to a car or to whatever they're using. So we really want to think about how can we make sure the informatics or AI interventions can be used by different people and also do not create biases. And, I'm probably preaching to the choir here that we do know that there are a lot of biases that exist when we create AI due to the systemic biases that are really embedded in our health systems and thus embedded in the data that we use to create both predictive and generative AI. So, I think a lot of times, and you all are probably more well-versed than I am in the computational approaches to reducing bias, but I try to think about inclusivity in terms of AI more in thinking about how do we make sure that the patient is aware of what's going on, that they are informed about what kind of AI is being used in a way that they can understand, and also that they're comfortable with it. Because, if you think about an AI tool that maybe makes a prediction and a health professional even acts on that prediction, if the patient does not take up the recommended action, even if it's efficacious, then it's, an unfortunate loss of time for everyone who's been involved in that whole process. So I'm going to talk about, three kind of research studies that hopefully show a bit of a trajectory of some of the work of, human-centered design of artificial intelligence, and then also talk about where we can go next. So starting in, 2018, 2019, I was involved in this PCORI-funded study where there was a quantitative arm of the study to use both regression and machine learning-based approaches to proactively identify patients that were at risk of high preventable utilization, which is always a mouthful to say. But essentially, the algorithm would determine people that they thought were going to, possibly be frequently using the emergency department, frequently readmitted into the hospital system in a way that was potentially preventable, to try and get people some more preventative care in advance, as opposed to, using those in the emergency department a lot, or they're being admitted into the hospital. And then, it was an interesting idea, but at the time, they didn't really even know who should be the end user or the person that is viewing the score. So for this particular study, we wanted to both inform the algorithm that was being developed about who should see this information, when would they see it, in what format, and then what are they going to do with it. But then, even at the time, about 4 or 5 years ago now, we did know that there were some really good strength of predictive analytics, but that, there hadn't been as much evidence showing their impact on outcomes. So we wanted to both inform this specific project and then also get kind of some implementation best practices to the extent possible. So we were able to interview people in 2 health systems in Florida and also a health system in New York City. As with any qualitative study, it's usually good to start with a theoretical model. We use Sivig and Singh's model of implementation of health information technology and complex socio-technical systems. And we were able to, it was unique such that not only were we looking at people from multiple health systems, because oftentimes, we're really focused on New York, we were able to interview 3 different stakeholder groups. And I'm going to show you a little bit more about them on the next slide. So as you can see, there was a lot of diversity in terms of the roles of people that we were able to talk to, because we needed to understand the current cognitive workflow of the people that would eventually use this tool. We also wanted to talk to clinical informatics professionals to understand what barriers to implementation there may be. And then at the end of the day, it's oftentimes kind of these operational C-suite level people that are making the decisions about what type of technology is purchased and implemented in the health system. So we thought it was important to talk to that group too about the potential value add of a tool like this, and how it could be presented if it was found to be highly predictive, how it could be presented in a way that, seemed valuable for the company to implement or for the health system to implement. So I'm not going to go through all of the results of this particular study, but there were kind of a couple of important pieces that I did want to talk about. So one of the first things that we noticed was that we saw a lot of people had mentioned that the socio-technical constraints were perceived as more challenging than some of the technical issues, meaning hardware, software, or some of the informatics related things. And these are the related dimensions in the model. And you can actually see here for one of the informatics people that we talked to, or one of the operational people we talked to, saying that there's not really a reason that it wouldn't be a good fit. It's more about kind of devoting the different resources. So essentially what people were telling us was that we have the technology and the infrastructure to implement these types of predictive models. But the important piece, as this person is saying here, is that socio-technical piece as to who is seeing it and what they are doing about it is kind of the thing that's a little bit challenging. And then this was helpful for me to think about. So for some people, maybe this isn't particularly surprising, but one of the first research studies that I actually worked on as a pre-doc was we were able to, and this was right when meaningful use stage 2 was going into effect in around 2013. We were able to go around the country to 11 different electronic health record vendors and interview them about their usability practices, or in some cases, unfortunately, lack thereof. But the reason that this finding that, the technical pieces weren't perceived as very challenging in this study that we did in 2019 was when we were doing these interviews in 2013. So in just, 5 to 6 years, the vendors actually discussed issues related to having enough clinical informatics expertise at the health systems level. So I think this was kind of an area that it was interesting that in just 5 to 6 years, it's been really amazing that the industry, especially thinking about people who do, the operational and clinical informatics, have developed these really advanced infrastructures such that when we were doing this follow-up study, no one was worried about, the technical pieces and the hardware. It was more thinking about who sees this information, when, and how. So that was just something that was helpful for me to kind of think about. And I thought other people may find it interesting because I think oftentimes we don't think back to a few years and how we've come and far we've come in terms of the ease of implementation of different informatics tools. The other thing that people found to be particularly important was that the support required to make information actionable really involved a conversation between the care team, the patient's, primary care provider, for example, the end user, and the patient. And this felt particularly important because essentially what they were saying is the end user of this particular predictive tool would likely be a care manager, possibly someone that's working for an insurance company or someone who's working at the hospital level, but it's likely someone who doesn't personally know the patient. And so what we heard from people was that it was really important for the primary care provider to be involved. Because if you think about it from the patient's perspective, if they were to just receive a call from a care manager they've never met one day, and this care manager is telling them, oh, we think you're at risk of high preventable utilization. I hope they wouldn't use those words, but a patient would probably be really taken aback by that and maybe a little bit scared, have a lot of questions about what's going on. So it would be challenging from the patient's perspective to receive that information. And you could see why the patient maybe would not want to engage with what that person was offering because it seems to be coming out of the blue. So instead, what was recommended was that the primary care provider first let the patient know, I see some things with your health that may be challenging in the future, and I'm going to have someone reach out to you. We know that they'll be very helpful and they can help make sure that you're supporting your care is as easy for you as it can possibly be. And the reason that this was important here and for, some of the work I'm going to talk about next is this was one of the first times in thinking about AI where people had really talked about if and how it interfaces with the patient. And that's kind of where the trajectory of some of my work in AI has gone, is thinking about how do we make AI a little bit more patient-centered. So in summary, we found essentially that it was really important that the algorithm didn't end with just identifying a person, but also helped sort out what types of recommendations could be made for this person. And then we also found important things, at each state of the process. So it was really important not to take humans out of the loop and involve different stakeholders very early on, possibly to pinpoint issues due to data quality, provide evidence as to how the tool may be a value add. So specifically, who was this AI identifying that was being missed by health professionals? And then people also just helped us think about what types of issues and challenges there may be planning for successful integration. And really the big thing here too, and what's transitioning into some of the other work I'm going to be talking about, is to consider if, how, and when the patient is involved and what they want throughout this process. So this is here, what I'm talking about too, is especially for a prediction like this, that does have some socially situated issues. So high preventable utilization could occur because the patient's sick, but maybe they have other social needs that aren't being met. For these things that are sensitive, how do we move from making AI that is more patient-centered as opposed to, what I've referred to as patient adjacent, meaning, always the goal of these systems is in some way to improve patient care, hopefully improve patient outcomes, or sometimes, improve the quality of a health professional's job. However, oftentimes when we're thinking about AI, unless it's something the patient directly interacts with, like a chatbot, we really don't think about the patient until the end of the process. And some of the work that we've been doing more recently that I'm going to transition into talking about tries to think a little bit more about how do we think about the patient, what they know about these AI systems, how these systems are being developed, and how that eventual informing of the patient, how that process happens in a way that patients are comfortable with, and in a way that diverse groups of people can really understand what are extremely complex mathematical models, essentially. This is not to say that we need a patient to understand how a machine learning algorithm is developed, but it's more to say that how do we make sure a patient, if we do think it can recommend an efficacious treatment, how do we make sure a patient's comfortable with that and will actually uptake that efficacious treatment that's potentially recommended to them? So I do have here the publication for this particular study if you are interested in learning more about this study, and also just wanted to note the funding details here as well. So I'm going to move into a couple of research applications that are describing the use of AI for mental health. Before I do that, does anyone have any questions that would be helpful before we kind of take a little bit of a different turn in what we're talking about? Okay, great. And feel free to put any questions in the chat. And I anticipate there'll also be a fair amount of time for questions at the end. So this is work that's funded by the National Institute for Mental Health. The parent grant is a risk modeling for postpartum depression. And then we were able to obtain what's called a supplement, such that we submitted a smaller application to be added to the current application. And we were specifically looking at bioethical considerations for implementing artificial intelligence for perinatal mood and anxiety disorders, and perinatal being the period either during or up to about a year after pregnancy is the way that we're defining it. So a little bit of background on the study. So colleagues of ours had the IRIS team, or the IRIS company is what we refer to them as, had developed a machine learning model that was able to proactively predict PPD, or postpartum depression, within 1 year of childhood using both claims and electronic health record data. This is actually, I think, a slightly older performance metric. I think they've even enhanced the performance a little bit more since then, but that paper is currently under review. But why this is helpful is oftentimes pregnant people or pregnant people that are postpartum experience pretty severe issues with depression. The incidence of depression is anywhere from 10 to 20% in the period after giving birth. And that's, I think, at least 2 to 3 times what we see in the general population. What the thought is here is that if we can identify people that are at a high risk for postpartum depression, we can get them into some supportive interventions during pregnancy, where they could potentially learn skills that would better help them cope and either not develop full-blown postpartum depression, or help at least decrease the severity of the symptoms that they could experience. But from a human-centered design perspective, we had a couple of general bioethical questions that we wanted to explore. So the first one is really thinking about how, mental health can be a really sensitive topic. And people also, have some, I think, doubts and reservations about the use of AI. So we wanted to learn a little bit more broadly about how people and patients feel about using AI for supporting mental health. So part of the reason that we thought this was important was because most of the work of explainability and implementation of machine learning models such as this one in healthcare have really focused on clinicians or health professionals. And there was a 2021 review that highlighted that pretty nicely. Given the 21st Century Cures Act and some of the anti-information blocking provisions, it is possible that patients could actually see risk score output before they have a chance to discuss it with their physician. Obviously, the healthcare team may be able to withhold some of that information if they don't think the patient could see it, but it's theoretically possible that some of these risk scores could be showing up in the patient chart and they don't know where it's coming from and really don't have context for what they should do with that information. And then in mental health care in particular, that therapeutic alliance between the patient and their health professionals is really important. And then we also know that there's a lot of sensitive nuances for how patients perceive mental health related issues as opposed to somatic clinical issues. So we thought it was important to investigate, how patients feel about the potential use of AI for their mental health care. So what we did is we actually had colleagues who had done a similar survey of patients focusing on somatic healthcare issues, like how do you think AI will change healthcare? Are you comfortable with AI, for example, reading your chest x-ray? But they didn't really investigate anything related to mental health. So what we did is we essentially took this survey, adapted it for mental health, and then also added some additional questions. So we use the online survey recruitment platform called Prolific. We had a pretty broad inclusion criteria such that they just had to be verified Prolific users. And the survey for this one in particular was only conducted in English, unfortunately, just based on resources and scope of the grant. But one thing that is helpful that is able to be done in some of these platforms is it was able to be balanced based on age, sex, and race to be reflective of the US demographic population. So the main things that we looked at coming from the previous survey were general perspectives on the use of AI for mental health care, potential concerns that people had about this approach, and then how comfortable people would be with having AI do various different kinds of tasks and that a mental health professional would usually do. And then since this work is focused on bioethical questions related to the implementation of AI, we also use this bioethical framework that you see here that's from MITRE to ask patients values in terms of what they would like to see AI doing for their mental health care. So this is the group of 500 people we were able to sample. As you can see, since that was part of the approach, pretty good representation based on age, gender, and race. Unfortunately, not as representative as we'd like to see based on ethnicity. And then we also did ask patients about their mental health history in various different ways, but there's actually a high percentage of people that did say they had a history of being informed that they had a mental illness. And that's important because a lot of work on patient perspectives on AI have shown that their personal experience with certain clinician or with certain conditions affects, how they perceive that particular tool. So one of the first questions was, we asked overall in the next 5 years, do you think AI will make mental health care in the United States? And people could either respond much better, somewhat better, neutral, somewhat worse, or much worse. Interestingly, only about half of the people described that they thought AI could make mental health care somewhat or much better. And then to understand differences in these perspectives, we also conducted a logistic regression with the referent category being the people who said neutral, somewhat worse, or much worse, versus the people who said somewhat or much better. And as you can see here, female gender was associated with being less likely to think that AI could make mental health care better. Interestingly, Black or African-American race was associated with being about 76% more likely to say that they thought that AI could make mental health care somewhat or much better. And then people who had inadequate health literacy were over twice as likely to really think that AI can make mental health care better. A couple of important things to note here is for this group that's actually pretty optimistic about AI and mental health care, it just demonstrates that any information that we're providing to people, we need to make sure it's inclusive to different levels of health literacy so people understand what is being done for them in their healthcare. And, we've presented this a couple of times about the differences based on race. And one potential explanation that people have offered is that based on the systemic injustices that Black and African Americans have faced in the health system, possibly there's a perception that AI is less judgmental and less biased than a person, which, this needs to be further tested. We definitely can't conclude this from this study, But that's also an interesting constraint when we know that oftentimes the biases we see are embedded in some of these AI tools. So this is something we really want to look into in the future, and make sure that, we can convey information about fairness of AI in a way that's easy for people to understand. So in terms of concerns about what could go wrong with AI, in general, people were really most concerned about getting the wrong diagnosis or, getting inappropriate treatment. People in general were like less concerned about cost and privacy. And there were kind of significant differences here based on the distribution across these categories. We also asked people how comfortable they would be with AI doing these various different tasks that we modeled off of the previous survey. Some of these are not particularly surprising here, that someone would not want AI telling them they had a severe mental health issue, such as bipolar disorder. And in general, what we saw is that people were not comfortable with these kind of like diagnosis delivery tasks and making any diagnoses of these severe issues, such as bipolar disorder, risk for suicide. People were in general a little bit more okay with AI recommending something such as talk therapy or a wellness strategy, essentially something that was non-pharmacological, but still kind of interest here, even for these things that people were more comfortable with. There's, at least 10% that are very uncomfortable with AI doing some of these things. It is important to note that the way the question was worded was asking AI to do this instead of your mental health professional. And what I think really requires further exploration here is how comfortable people are with AI doing these things in tandem with a mental health professional. But still really interesting here, just showing kind of low levels of comfort, particularly for certain tasks. As I mentioned, we also asked people how important some of these various different values were in terms of what they wanted AI to do for their mental health. And what was somewhat surprising was actually the most important one was what we would call explainability of AI. We weren't sure that patients would necessarily know that term, but people really wanted to understand what individual risk factors they had that were driving. We used depression as an example for this particular question. And it was really interesting for us to see this because I know with health professionals, we're using approaches such as, SHAP values and other information to reverse engineer the algorithms that are created. So we can let the health professional know, we think the patient is at high risk for these XYZ reasons. But I have not seen much, if anything, for thinking about how do we communicate this information to patients. And one thing that we're, trying to explore is sometimes these, the things that make patients at high risk are non-modifiable factors or factors that could be considered sensitive. And, patients want to see this information, but how do we make sure we convey it in a way that's both sensitive and helpful to the patient? So for example, for this particular risk prediction algorithm, one of the factors that has been shown to be associated with postpartum depression is morbid obesity. So, I think that's something that if you told a patient in that way, that would probably not be very helpful to them and maybe off-putting. Another thing that has been linked with postpartum depression, a data point in this particular sample, is being single, so unmarried. And, that's another thing that it's probably not particularly, it may not be particularly helpful to tell that to a patient. And it may actually be offensive for you to remind a patient of that when it's not necessarily something they can impact or control. So I think there's really a lot to be done to balance patients wanting to see this information to better understand their individual health, but thinking about how we can do that in a way that's sensitive and supportive and not perceived as judgmental. So a couple of additional things that we found for some of the other questions. Oh, another thing I wanted to say here that I think is important just to notice is, in general, patients valued all of these things pretty highly. So even the thing that they valued least, so, not reducing this trust in your mental health professional, over 80% of people still view this as very or somewhat important. So we also noted that, the transparency, but 73% of people, so almost 3/4 of the sample, said it was very important when they know when machine learning or AI plays a large role in their mental health diagnosis and treatment. This is particularly interesting because this is definitely not currently the standard of practice in terms of informing patients when, AI or a machine learning algorithm plays a role in their treatment. This was another thing that was particularly concerning given the really importance of the therapeutic relationship. Over 50% of people said that if an algorithm was accurate 80% of the time and it disagreed with their mental health professional, it would make them question that professional's judgment. So I think that's a really additional important piece to think about. How do we use AI in a way that is supportive and additive to that therapeutic relationship and not putting it at odds with the patient and the mental health professional? And I think for mental health and professionals in particular, this will unfortunately be further concerning, that a majority of people, actually over 80%, when they had to pick who was responsible for medical errors related to AI, thought that it should be the health professional. People were a little bit more divided on a question about ensuring safety for AI, but this was something that I think is, really important to think about, because oftentimes it's not the mental health professional who is developing these algorithms. But the people were really, unfortunately, thinking that the blame for misdiagnosis and treatment would go towards that health professional, which is something that's also important to consider given, the issues we have with our healthcare workforce today and not having sufficient mental health professionals and health professionals in other roles. So we also had patients give some qualitative feedback. I did focus on some of the most concerning things that patients had to say. So we found different themes related to people talking about the performance of the AI, dynamics between humans and AI, and other additional concerns and values. So as you can see here, there were people who were concerned about bias. So this is something that people have heard of in the past. This one actually is, incidentally, I accidentally included it twice, but I think it's an important one. Going back to what people were most concerned about, it was misdiagnosis. And people have this really severe concern, like imagining that AI could lead them, in this case, to ending up in a psychiatric ward, for example. And then this one I think was important, really thinking about that therapeutic relationship. And kind of a heartbreaking thing for one patient to say that, I found a doctor that made me feel understood, heard, and cared for me. It resulted in effective treatment for my major depression after suicidal ideology after many years, and AI can't do that. And then there were, even kind of more severe issues that people expressed here. One thing, though, that is important to point out is I think a lot of these quotes are in the context of AI replacing a mental health professional. Other quotes that we saw showed that there was somewhat of a consensus that people may be okay with AI providing information to mental health professionals, but they really wanted the health professional to be the ultimate decision maker, which I think, is in line with kind of the status quo today. And then people also expressed additional concerns related to privacy and ethics. One of such being that they wanted AI to be used for the right reasons, which to them was to promote health outcomes. And they didn't want to see AI being used to make profit, basically, from an insurance setting. So I think this, is an important survey design consideration that, people had some concerns from a quantitative perspective, but then what they put in the qualitative feedback, showed even a, potentially higher degree of discomfort, and really gave some language to some of the quantitative concerns that were expressed. In this particular survey, we actually did, usually these open-ended kind of response questions are optional. We actually did make them mandatory. So people could put NA if they had nothing else to say. But I think that was actually a helpful tactic that made people think a little bit more about what this would mean for them and give us some really helpful feedback about what they were thinking and feeling about these approaches. So we have published part of these results in a special issue looking at people who pregnancy capable people and differences in what they may think about the use of AI for mental health. But some of the big findings from this particular survey is that there were significant differences based on gender, race, and health literacy regarding people's optimism for AI, which again goes to the inclusivity piece of thinking about how we may communicate this information to patients in the future. There was unsurprisingly some variability in comfort with different tasks that AI could complete, with people being specifically uncomfortable with AI doing any diagnosis delivery or recommending pharmacological interventions. The thing that was highest valued by the participants was understanding risk factors that were driving AI's decisions. And then, as we just looked at, we saw that, the qualitative feedback revealed some pretty grave concerns about using AI in a mental health setting. And I think, once again, the important thing to investigate here is more of the status quo of how do people feel about AI being used in tandem with a mental health professional, as we see people are quite uncomfortable with having AI be used exclusively for certain things. So in addition, we also wanted to think back to this specific use case of postpartum depression and a model that could be telling patients what their risks are. So we wanted to think a little bit more about how could we show model output to patients, given that these are, pretty complex mathematical models. So what we did here is we once again had another sample of prolific users. The big difference in this particular sample here is we focused on pregnancy-capable adults of childbearing age, given that this is something that would most impact them. They did not have to have a history of a previous pregnancy, because we also wanted to think about people who could become pregnant in the future. So we, based on an ongoing systematic literature review of communicating single value risk, so this really is a single point in time % risk of postpartum depression, as well as other literature, we designed 4 different ways for conveying this risk to patients. We used a randomized block design that I will show in 2 slides. And our main outcome measures were risk classification. So was a patient able to determine if their risk was below or above the recommended treatment threshold? And that was really our primary outcome. We essentially wanted to assess a relevant question related to comprehension. We also asked people about their perceived magnitude of developing postpartum depression, worry, preference, trust in information, behavioral intention. And then we had seen some previous literature that certain visualizations could better help people understand that a number was a continuous variable, as opposed to it just being above or below threshold. So we created some additional questions to evaluate if people understood that, a score of 80 was actually much worse than a score of 40, even though they're both above that threshold for seeking treatment. So these were the 4 things we tested, and sorry that this is a little bit blurry. So we had a text condition where we just told people they're above the threshold, a numeric only condition, and then we had 2 different segmented number lines. There was a previous study that I had cited in the previous slide by Brian Zickman Fisher that had found that these number lines were a good way of communicating single risks like this, and also that this gradient number line could potentially help people better understand that the risk was a continuous variable, and also determine what they should do for more borderline cases. And we had, based on some of the previous data from the algorithm, set this risk threshold at 30% for probably may not need treatment, or preventative services may not be necessary, versus preventative treatment should be considered on the 2 different ends of the spectrum. So we had 504 participants. They were randomized to the following blocks. So each person saw each presentation format once, and then it was counterbalanced based on the actual number of the risk score. So we had one kind of low value at about 8%. We had a borderline low at 28%. A borderline high at 32%, and then a very high at 80%. And this just allowed us to assess some different interactions, because what the patient may need to know or need to do is obviously tied to how high the risk is. So this was the sample that we were able to define. a pretty good actual representation in terms of gender minorities, I think, which was helpful to see, given, that you don't necessarily need to identify as female to be capable of becoming pregnant. And then we also, had a little bit less racial diversity than we would typically like to see. So I think this is something that we're going to try to remedy in future studies that we're doing by trying to have a more diverse sample for interviews that we're going to be doing soon. And then in general, we had, what you would typically expect in terms of health literacy. Usually you would expect to see about 2/3 of people having adequate health literacy. And then a pretty good representation in terms of subjective numeracy and graph literacy. And then we did also ask people, once again, about their history of major depressive disorders, just to understand how they may attach to this information. And, over 1/3 of people did endorse a history of previous depressive disorders. And then for people who had, we did actually have a fair amount of people who were not currently nor had ever been pregnant, about 60% of our sample. So we did in one of kind of just try to look at pregnancy history and how that could potentially affect some of their different perceptions, although I'm not exploring that in this talk today. So our main results were essentially that there was no significant difference in the different presentation formats based on that primary outcome of were people able to determine if they were above or below the risk threshold. I think we saw, honestly, a ceiling effect here. It's a relatively straightforward question to see, is the risk that you're being shown above or below that threshold? So I think, in the future, it may be good for us to investigate more complex questions that may need to involve, more inference. There was also no difference in the different presentation formats based on if people understood that it was a continuous score and not just a treatment recommended or treatment not. I'm going to dig into these a little bit more too. There were significant interactions based on the presentation format and the risk level, which makes sense. If we found a significant main effect of the risk level for all of these, risk perception and worry, which is not surprising. You would anticipate people would perceive the risk to be higher and be more worried if they are shown a higher number. And I'll talk about that in the next slide. And then the most preferred format was the gradient number line. That was the one that was in the bottom right corner. So we were trying to dig into some of these interactions, and it was a little bit difficult because it wasn't such that, like, for the 80% category, we always saw the same presentation format leading to the highest behavioral intention or risk perception. But what is interesting here, we tried to put this into a graphic. So I highlighted the things in this dotted line or in red for people who are able to see the colors of basically what you wouldn't want to see. So at this lowest risk, you don't want people to be seeking additional care, to have a high risk perception, or be particularly worried. So it was interesting such that the numeric condition, so the percent only, was actually the thing that led to the greatest behavioral intention, so seeking care, essentially the highest perceived risk, and the most worry for the lowest risk level, which is not what we want to be seeing. Although on the other end of the spectrum, in this highest risk condition, to see things tracking appropriately, there's where we would want to see the greatest behavioral intention, the highest perceived magnitude, and the most worry. It was also the numeric condition in every instance that led to kind of the most, the responses that were most in line with the risks people were seeing. So this is something that I think it warrants further investigation, such that it seems that there's some evidence that with this numeric condition, people were maybe overestimating their low risk. Another thing that was interesting was, we didn't have as many significant findings for our main outcome, but we did see that in terms of trust, that people rated trust the lowest for every condition for every risk level, when they were shown the just text condition and not given that risk estimation. So, what we really learned here is that as I mentioned, there were not any significant differences based on that primary outcome of risk classification. And I think, as I mentioned, it'll be important to study, possibly more complex comprehension related outcomes in the future. The text condition was the least trusted. This is actually consistent with the IPDIS, the International Patient Decision Aid Standards. They recently, about a year ago, came out with the more updated recommendations for communicating new numbers to patients, and did recommend that we shouldn't be using what are called verbal probabilities only. We should always, if we say something is likely to happen, we should also always provide some type of number to help the participant interpret what we're talking about. There were some indications that the numbers only condition could have been associated with overestimation of low risk. This does require further exploration, but it is consistent with information that we know that graphs or visualizations can actually be more helpful for people with lower numeracy and understanding their risk. So that is possibly where that could be coming from, but that requires a little bit more explanation. And we did note that the gradient number line was a preferred format, but we will want to keep evaluating this because there have been a lot of studies that have shown that the most preferred format isn't always the one that does the best with comprehension. So it's something that we will want to keep an eye on for sure. So this is what we're thinking about in terms of future work. So we actually recently started interviewing current or recently pregnant people about, their values related to AI, showing especially as it pertains to postpartum depression. And since there's so many people that are involved with supporting, diagnosing, and treating pregnant people who may be experiencing mental health issues, we're also going to be talking to care team members, partners, and then the technology members who may be involved in some of this information. And going back to the previous survey where we found that people wanted more information about the variables that were driving their risk scores, we're also thinking about some survey studies where we can try to better understand how to show variables that are driving risk scores to patients in a way that is sensitive and supportive to them. So that is what I have for kind of this main content. These were the two, main funding studies I presented. This is, what we're thinking. What does kind of a dashboard for conveying this information look like, supporting some of these bioethical principles? But I can stop here and take questions, or I do have a little bit of bonus content that I can go into about generative AI. Carrie, go ahead.
Hi, wonderful presentation, very interesting work. Thank you so much. I'm wondering about, given what you stated in your first presentation about differences in perceptions based on demographics like race and health literacy, did you see any differences here in terms of preferences or, the outcomes that were measured across those dimensions as well?
Mm-hmm. So we did not evaluate differences based on sociodemographics. And it was unfortunate but the way that the study was designed, we only would have been able to do that using a three-way interaction, because we would have had to look at presentation format, risk level, and the sociodemographic variable. And we unfortunately just weren't really powered or set up to do that. But I think that's really important that at least, especially thinking about preference and comprehension, that hopefully that's something that we can explore in future studies. So fortunately couldn't do it here, but that's a really good question and something I think we need to think about. I think I saw Adit's hand next.
Yeah, so I think something that you mentioned towards the end of the presentation was that a lot of people either overestimated or put an additional level of just consideration and trust into the usually numeric scores that they received. And at least for looking at it from a sports analytics comparison, that could just be because people like to put value in capture metrics that are able to represent the current state of something in its totality, whereas with what is there with the risk score, that's something that can capture all the context, and as you mentioned, does need some kind of additional way to communicate what the things to consider are when interpreting those values. So I guess my question is, do you foresee that as something that needs to be communicated from the get-go when patients are using these kinds of applications, or more so when numbers are presented throughout the workflow of using different applications?
Great question. So I think if I'm understanding it correctly, is you're wondering, if there need to be more holistic metrics that convey, how certain we are about the risk score potentially, or the performance of the risk score. Am I understanding correctly, or is that approximately what you're asking?
More along the lines of like when in the workflow process is it necessary to communicate that, but I guess that too, in a sense.
The short version is we are currently asking patients about that, or participants about that, in semi-structured interviews to just better understand. So the people we've talked to so far for this particular risk score have wanted to see this information during pregnancy, and in general, thus far have seemed interested in seeing it, although we're not particularly far into the study. And it's, once again, another area that we're going to keep continuing to explore. And then I saw Laura has their hand raised, and then I'll also answer the questions in the chat after that.
Yeah, I have a question. Can you hear me? I hope
Yes.
you can hear me. Okay, thank you. Thank you for the very interesting talk. It's regarding the first part of your talk, where you were talking about human-centered design, and I worked in the medical field before I joined DBMI, and in my experience, it's always been also an issue with those new tools and AI tools that the providers have almost sometimes kind of an aversion to using new tools. And is there any research going on looking at that, looking at how can we improve, how can we encourage people who might have fears or technological challenges to implement those and to help their patients? Is that something that is being studied?
Definitely. And so that's actually being studied extensively, although it's quite complicated. And I don't know that people have really found great best practices for helping health professionals trust highly predictive AI. But part of the reason we focused on patients in these second two studies is based on the fact that there are a lot of studies and information out there that focus on the health professionals instead. And I think going back, so it's back a lot of slides at this point, but there was a review that was done that found very few instances of showing some of these tools to showing some of these tools to patients. But in this review, they did find, a myriad of papers where they are trying to understand how can this information be shown to health professionals. And one thing I have seen is there are a couple of studies that have shown really helpful dashboards that have been used to promote trust in AI for health professionals. Oftentimes they do include, for an individual patient, what are the main drivers of the risk score, because that's important for decision making. And people are also to investigate all of the variables that are included if they want to. So there have been studies out there that have done that. And I think this segues nicely into the question in the chat in terms of thinking about, sorry, I'm just, oops. Okay, so existing frameworks to analyze the dynamics in the clinical encounter. So there's a lot of what I think are pretty helpful frameworks from the human-computer interaction and human factors literature from, it's going to sound crazy, but from like the 80s and 90s, when we were first developing automated systems in factories. So there's a lot that's already been done about trust in technology broadly. And, some of us have had perspective papers thinking about how we apply that in a healthcare setting. And it's unsurprising that people want to know what's driving the AI risk score, because we found out, 20, 30, 40 years ago, that people in general actually better trust a technology that they understand how it works, even if it's not as accurate or high performing. So I think that was one question in the chat, and there is another one here. Feel free to unmute yourself and ask it, but I will just give me a second to read through this. Okay, yeah. So why people with inadequate health literacy may be more optimistic towards AI integration. I think the answer is we don't know. One thing that we didn't look at, and I think may be helpful too, is there's something that's called the control preferences scale. So basically how involved patients want to be in their own care. And sometimes for people with lower health literacy, they're just more deferential to a health professional or whatever it may be. So if I had to guess, not having as much evidence behind this, I would guess that it's in general just like a deference to authority, possibly based on, just having lower health literacy and possibly lower confidence in being involved in their care. In terms of combating issues related to trust, if the patient and the AI disagree, I think this is just a really ripe area that we need to explore a little bit further. I am wondering if it's important. One thing that I've seen is allowing health professionals to adjudicate or say why that they think the AI may be inaccurate for this given patient or individual, and thinking about ways that could actually be used to convey that information to patients in a way that promotes trust in the health professional as opposed to degrades it. I do see that we're at time. I do have my email on this last slide. I can scroll through to the end. So please feel free to, reach out, email me with any questions that you may have. There we go. And thank you again for the opportunity to speak with all of you.